Welcome, folks. As you come in, please feel free to indicate where you're coming in from. And if you're associated with a Center for AIDS Research or CFAR site, please indicate which site. Got a good group joining us, and we'll just give it a minute or two because we anticipate a bigger audience. Great. Please do feel free. We'll start in one more minute, but folks are adding in, and we've got people from US, from Botswana, and it's great to see a variety of people joining in. Just indicate where you're coming in from in the chat. Great, so let's go ahead and get started as people are joining. Welcome to today's Inter-CFAR collaboration on HIV research and women. We've got an exciting panel of three who will be presenting on menopause. And we're going to encourage you as they present to put any questions into the chat, and each of them will present, and at the end we'll open it up to discussion from the group, fielding your questions. And I think that's all the opening comments I have. So with that, I want to introduce the first panelist. This is Bridget Picot, and she's a licensed vocational and certified AIDS care nurse in Palm Springs, California. And she works with the Well Project. It's a nonprofit organization whose mission is to change the course of HIV/AIDS pandemic through a unique and comprehensive focus on women and girls across the gender spectrum. Her role in the Well Project is stakeholder liaison, and she represents the interests of women living and affected by HIV in medical, research, and policy, as well as advocacy spaces. She's also the director of at-large for the Association of Nurses in AIDS Care, and a sitting member of the board of directors for HIV and Aging Research Project in Palm Springs. She sits at the intersection of being Black, a woman, and a person living with HIV. And her goal is to remind people that there are lives being lived that are more than just a three-letter acronym. So with that, Bridget, I'll have you take it away.
Thank you so much, Kate. I appreciate it. And I appreciate the opportunity to be here. I'm just going to take a brief few minutes to kind of talk about the lived experience perspective of HIV and menopause. The intersection that was missing from my bio is that I'm also dealing with menopause right now. And it has been a challenge. And so I want to talk a little bit about that. I actually would like to start with a quote from Audre Lorde, which says that there's no such thing as a single issue struggle because we do not live single issue lives. That is absolutely true of women living with HIV. It is true for all of us in the times that we find ourselves in. And so it is something to consider as we look at and think about the whole woman and the whole experience of HIV and menopause. Menopause is a transition that is particularly impactful for women in general, but especially for women living with HIV because their lives have already been impacted by acquiring HIV in the first place. HIV in itself is a transition that involves confusion and shame and uncertainty and guilt, and it creates a series of unanswered questions for women. And when you add menopause on top of that, which also comes with those same sets of circumstances, it becomes not just impactful, but profoundly can influence the relationships that women have with themselves, with their caregivers, with their healthcare providers. And it is something that needs to be examined through a broader, more feminine lens. It took me a long time to realize that I was in menopause because the conversation wasn't being had with my clinician through no fault of his own. And I had convinced myself that I was experiencing some horrible opportunistic infection, even knowing everything that I know about HIV, even working in the HIV field, because I was so confused about what was happening. It became a very frustrating thing. I was diagnosed with HIV at 40, which is already a transitional period for women. And so it became a really confusing question of, is what is happening to me a result of HIV? Was it a result of the HIV medications, or was it a result of the HIV disease process itself? And then when the symptoms of menopause started creeping in, it became even more confusing. So when we talk about menopause, there is stigma obviously associated with the transition into menopause. So we're talking about issues that impact quality of life. It impacts our overall sense of vitality, our overall sense of health, and also the way that society looks at us within, that lens. The confusion over menopause is made worse because so many of the symptoms of menopause seem to overlap those that are involved in the HIV disease process. And so it's important for us to have conversations with women early and often about what menopause looks like, and not just waiting until a woman is over 50 to have these conversations. Because as we know, HIV accelerates the aging process. What we don't know is how much that happens, and how much the effects of medication and the length of time that a woman has been living with HIV can impact the age at which she starts to experience menopause. And when I say that, I'm thinking specifically of dandelions or lifetime survivors, those who acquired HIV at birth or early in life. There definitely needs to be more study for them. And because many of them are now approaching their 40s and starting to get into that age range where it becomes important to know all that they can about menopause. Some of the things that have impacted me personally, I like to talk in I statements. There is a broadness that can be applied to it because obviously in my advocacy, I've talked to other women, and for women, storytelling is a lot of the ways that we are able to communicate and learn things, right? And so through storytelling and listening to other women, I can say that menopause exacerbates already existing conditions, which is probably not a surprise to you all, right? Like, so my depression was exacerbated. My anxiety was exacerbated. And then when you started adding in things like insomnia and fatigue, those had an impact on the way that I looked at myself and the way that I looked at my HIV. Again, like I said, there was confusion about what was happening to me. I did not have the classic hallmark sign of hot flashes. I did have cold flashes. I do have where I go from hot to cold, unexpectedly. My anxiety definitely was exacerbated. I was in a space where I felt like things were starting to go well, and then all of a sudden they weren't. And so just keeping in mind, again, that we need to look at menopause and HIV as we consider the whole woman, right? The whole experience. Women don't know what they need to know until they need to know it. And it is our responsibility as healthcare providers and advocates to be able to provide them that information, sometimes before they need it, so that they can approach what is happening to them from an informed space and a confident space that they're going to be okay. I would just leave you with this before we move on to the next. There are practical ways in which we can have conversations with women about HIV within a clinical setting, because menopause and the effects of menopause have a definite impact on engagement and care. And adding HIV and menopause and the layering that those two things have also have a profound impact on engagement and care and the way that women approach care at what is really a critical time in life as they are aging into the additional things that come with being an older person living with HIV. And so I will stop there and happy to answer questions later on in the webinar, which I hope we have time for. So thank you so much.
Thank you so much, Bridget, for that initiation of the webinar with that really personal experience. My name is Maria Alcaide. I'm the co-chair of the Inter-CIFAR HIV and Women Working Group, and it is my pleasure to introduce our second speaker, who is Dr. Michael Yin. Dr. Michael Yin is an infectious disease specialist and professor, associate professor at Columbia University in the Division of Infectious Diseases. His research focuses on HIV and on non-infection and aging-related complications of HIV. He has evaluated the epidemiology and pathogenesis mechanisms of HIV-associated bone loss in postmenopausal women, in adolescents, and in other populations, such as in children with perinatal infections. In addition to skeletal complications, Dr. Yin has also studied the impact of HIV and antiretroviral therapy on metabolic syndrome, obesity, frailty, and falls, certainly conditions that affect women as they age. Thank you so much for being with us today and talk about HIV and menopause.
Thank you for that kind introduction.
Michael, you are
My
not
slides
on.
are not there yet.
Yeah, perfect.
You can
Now
see the
it's good.
slides now?
Now it's good. Thank you.
Okay, great. Thanks so much. Let me see. There we go. So Bridget very, very eloquently illustrated the reasons why we should talk about menopause. These are sort of 3 points that I thought were pertinent. One is that, in the general population in the United States, over 50% of women living with HIV are over the age of 50, and this is around the time when menopause happens. There are unique ways in which reproductive aging impacts women living with HIV, and those we'll discuss in this talk. And then the most important one, I think, that Bridget outlined very clearly is that women living with HIV and their providers may not be aware of treatment options for vasomotor symptoms. And so this is another big reason why we should talk about it. So what is menopause? Menopause is the cessation of menstrual periods. The definition is of postmenopause is once you have not had a period for greater than 12 months without another cause that could be a pathologic or a physiologic cause. It reflects the depletion of ovarian follicles, resulting in low estrogen levels that decline and a subsequent increase in follicle stimulating hormone as a way to try to drive the ovaries to secrete more estrogen. This is a very complicated slide, and it illustrates the main research tool that we use to define the stages of reproductive aging. So there are 3 stages: reproductive, the menopausal transition, and then the postmenopause. The menopausal transition is also referred to as the perimenopause. The main thing I wanted to illustrate on this is that the main criteria that we use to classify these stages of transition are based upon the menstrual cycle. But in people who do not have a uterus or for other reasons are unable to use that data, you have to define the menopausal transition and the postmenopause by supportive criteria using hormone levels such as FSH, estradiol, and AMH. So what are the hallmark symptoms of menopause? The main one is the vasomotor symptom. This is also known as hot flashes or hot flushes. And it's a sensation of heat that begins on the upper chest and face and then spreads. It can be associated with sweating and palpitations, chills and anxiety. It occurs several times per day, maybe more so at night. And in that situation, it can be referred to as night sweats. They last for 2 to 4 minutes. And it occurs in about 40% of women in that early transition and more, 50 to 75% in the late transition and early postmenopausal periods. On average, these symptoms could last for 7 years during the menopausal transition, but for some women, it may last more than 11 years. Here are some of the other symptoms that are associated with menopause. There are depression is a major one. You could have an increased risk of new onset depression. Sleep disturbances are very common, and this is in some ways tied to the number of vasomotor symptoms that occur at night. Cognitive changes occur, described as forgetfulness or difficulty with word retrieval or brain fog. And then genitourinary syndromes such as vulvovaginal dryness and dyspareunia happen commonly. Here are some, in the figure, other associated symptoms. As far as when menopause happens in women living with HIV, the mean age of menopause in women without HIV in the United States is 51 years. From various studies in cohorts of women living with HIV, the age of onset ranges between 46 and 51 years. There are differences between the studies in terms of the methodology, how they classify the onset of menopause, versus differences in the population in terms of sociodemographics. And so there's a range in the studies as far as what they estimate to be the age of onset of menopause. But on the whole, it appears that the age of onset for menopause with women with living with HIV is a little bit earlier than that of the general population. Do women with HIV experience more frequent vasomotor symptoms? There have been several good studies that have looked at this. The first two listed in this table show that there's evidence of increased prevalence of hot flashes or more days with hot flashes and greater severity of hot flashes. But other studies have found no difference between women living with HIV and those without. So there may be differences, but it's not clear across all studies. But there are implications of menopausal symptoms that are quite unique to women living with HIV. And I think Bridget brilliantly talked about one of those. And here's another testimonial about that association with the onset of the symptoms with symptoms of HIV. The greater frequency and severity and the duration of vasomotors in women living with HIV can also be associated with care of their HIV. So there are studies that have shown that the vasomotor symptoms and the other associated symptoms of menopause were associated with the reduced adherence to antiretroviral therapy or greater symptoms of depression and anxiety and worsened cognitive function, which have effects not only on care of HIV, but also the long-term quality of life for people with HIV. Another very important aspect is we know that people living with HIV are at higher risk of cardiometabolic problems, and there is evidence that what happens in the menopausal transition increases that risk, both in terms of the biomarkers and also imaging of the heart. So what are treatment options for vasomotor symptoms? And it's important here to recognize you're not treating menopause, but you're treating the symptoms associated with menopause. Hormone therapy is the most effective therapy for those vasomotor symptoms. And it also works to prevent menopausal bone loss. The options include estradiol, plus or minus progesterone. Progesterone is necessary if you have an intact uterus to prevent the hyperplasia of the endometrium and potential cancer. There are different formulations that are available in oral and transdermal. Transdermal comes either as a gel or a patch, and you put it on your skin. And there are vaginal formulations when the symptoms are very much just specific for the genitourinary symptoms. As far as non-hormonal therapies, there are lots of things that have been tried and studied. The best reference for this is the North American Menopause Society position statement. They put out one in 2023 that discussed the non-hormonal formulations that they recommended and did not recommend. Among the recommended ones include cognitive behavioral therapy. So this is a non-medication option. Selective serotonin reuptake inhibitors and SNRIs, which are used to treat depression, but also have been found to be effective in treating vasomotor symptoms. Oxybutynin, gabapentin, and fezolinetant, which is a very specific medication for vasomotor symptoms that targets the neurokinin B pathway, but has not been studied in HIV. None of these have specifically been studied in HIV. So that's another issue that we'll discuss later on. As far as hormone therapy is concerned, it is the most effective treatment for vasomotor symptoms and for the genitourinary syndrome of menopause, and has been shown to prevent bone loss and fracture. In women below the age of 60 or within 10 years of menopause, the benefit to risk ratio is favorable for using hormone therapy. So there was a big study called the Women's Health Initiative that indicated there were increased risks with cardiovascular events in people on the combined equine estrogen regimen that was used in that randomized clinical trial. And that really changed the way that people prescribed hormone therapy. There's a big drop-off in use of hormone therapy for treatment of vasomotor symptoms. But over the years and the reanalysis of that data have found that there were real differences between the group that were younger than the age of 60 and had less than 10 years of menopause. And the risk of hormone therapy in that group was extremely low, especially on the important outcomes such as breast cancer, venous thromboembolism, and stroke. So that's what led to this recommendation that in women who are under the age of 60 or within 10 years of the menopausal onset, that the risk-benefit ratio favors use of hormone therapy for treatment in this population. You can still use hormone therapy in the age group above 60, but then you have other considerations. As far as non-oral routes of hormone therapy, such as the transdermal with either a gel or a patch, this avoids the first pass metabolism in the liver, which produces proteins that add to thrombosis. So if you're using the transdermal formulation, you have even lower risks of venous thromboembolism. As I alluded to before, there are no specific data about hormone therapy in women living with HIV. There are studies that have looked at observational cohort data, such as the Y study, and those appear to be favorable. Overall, hormone therapy is not very widely utilized these days, even in the general population, and quite low among women living with HIV. We did a study looking at the WISE cohort, which has had data for many, many years, and we found that among women who were surveyed in 2003, 19% of the postmenopausal women reported being on hormone therapy, whereas in 2017, only 3% were on hormone therapy. And in surveys done both in the UK and the US, it seems quite related to the provider confidence. So in England, primary care providers are responsible for managing menopause in the general population. And they felt comfortable doing that for all their patients in the general population, but only 45% of the providers felt confident managing menopause in women living with HIV. And this they're alluding to their insecurity about what potential drug-drug interactions are and what it might do for their HIV care. In the US, there are a lot of infectious disease or HIV specialists who actually care for people living with HIV and do primary care for them as well. So on that side, I think more of the provider insecurity is about how to treat menopause and what to do about hormone therapy and other options. This is a nice summary from an article recently published that Sarah Luby presented in the CROI presentation that illustrates some of the potential interactions between hormone therapy and antiretrovirals. And you can see that for specific NNRTIs, there are potential interactions, but not with others. And there are potential interactions with protease inhibitors. But importantly, there are no interactions between hormone therapy and integrase inhibitors and NRTIs, which are sort of the mainstays of a lot of our therapy. So in light of the gap in knowledge about the efficacy and safety of hormone therapy in women living with HIV, we've been working on a study for many years now to look at hormone therapy by way of a transdermal formulation. You can see pictured here in a gel pack. The main goal of the study is to look at its effects on vasomotor therapy, but we are also taking advantage of this first study to really examine safety and tolerability and neurocognition, mood, sleep, quality of life, sexual function, and weight. We are also interested in looking at bone turnover markers, markers of cardiometabolic health, inflammation, immune activation, the HIV reservoir, including work that Dr. Scully is going to work on, she'll tell you about, and the rectal and vaginal microbiome. We are also interested in doing ambulatory monitoring, which is an objective measure of hot flashes in this study as well in a subset of participants. This will be a randomized clinical trial of estradiol gel plus progesterone in people who have intact uteruses to placebo. And it's going to be run through the ACTG. And we are hoping that the study will be on track to open in the fall or winter of this year. So with that, I'd like to just acknowledge the study team that have worked very hard on this study, and in particular, Sarah Barris and Sarah Luby, who are the co-chair and the vice chair of the study, who also kindly provided me many of the slides that I presented. So that I will end my portion of the talk and happy to take questions at the end of all the sessions.
Great, Michael, thank you so much for that. It's fascinating to hear the challenge of people who feel very comfortable handling HIV care, but maybe not so comfortable handling menopause or vice versa. And I think that may be a challenge for many people who are listening in today. So that'll be an interesting gap area to address, and the research that is proposed certainly should help with that. Please feel free to put any questions you have into the chat. And with that, we will move forward to Dr. Eileen Scully's presentation. She is an associate professor of medicine at the Johns Hopkins University, and she earned her MD and PhD in immunobiology from Yale School of Medicine and completed her internal medicine residency at Brigham and Women's Hospital in Boston, followed by an infectious disease fellowship in the Harvard Combined program. She did an additional dedicated training as an HIV fellow focused on clinical care of people living with HIV, and after that postdoctoral fellowship at the Ragon Institute, which is a collaboration between Mass General Hospital, Harvard, and MIT. She started her lab studying HIV immunopathogenesis and cure, and she moved her lab to Johns Hopkins in 2016. She is active in translational research, co-chairing an interventional cure trial through the AIDS Clinical Trials Group, or ACTG, specifically in women. And she also serves on our executive committee of inter-CFAR collaboration of HIV research in women. At Johns Hopkins, she teaches a longitudinal curriculum on HIV to the infectious disease fellows and leads a weekly Center for AIDS Research, or CFAR, clinical conference. And Eileen is also the co-director of the CFAR Clinical Core and cares for individuals living with HIV, both in the outpatient and inpatient settings. So with that, Eileen, I'll turn it over to you.
Well, thanks so much, Kate, and thanks to everyone for being here. So I am going to try and talk a little bit about mechanistic questions in this area so that we can try to think about how we can best design research, whether it's clinical or translational, to get us closer to newer treatments. And so first off, I just want to start by making the, maybe uncontroversial statement, but that menopause is not the same as aging. And I think that establishing that helps us to think about what the kinds of controls are or things we need to consider as we build studies is really important. So there are both unique and overlapping aspects of aging and menopause. And if we're going to develop therapeutics that are targeted, we need to parse their individual contributions to clinical outcomes. And so let's take that from like sort of a theoretical idea down into a specific reality. So here on the left is the data from the Framingham study from the 1970s that followed both men and women and measured the incidence of cardiovascular disease over time. And as you can see, as you get older, there's clearly an increase in incidence with a sharp uptick after age 74. But what's not immediately visible from this is the impact of menopause. So here what I've done is broken out the women categorized as either premenopausal or postmenopausal. So on the left side of the graph, the sort of mauve, light mauve, is premenopausal at the same age stratum, 40 to 44, as postmenopausal women within that age stratum, which are the dark red bar. And then all the way over on the right, this blue is not men, it's the overall collapse data for all the people under age 55, either pre or post. And what we're looking at is the cardiovascular disease incidence. And what you can see is that at every age stratum, it increases with age, but your status as from a menopausal standpoint is actually quite important for your risk. And I think that what we can sort of take from this is that there's a contribution of both age and also reproductive status. And so in modern science, I think we have a much more nuanced understanding of age itself. So there's classic chronological age, which is simply the number of years that an individual has been alive, and that's one consideration. But now we also consider biological age, a metric that's supposed to reflect overall health and the rate of aging in an individual, which bears the impacts of both chronic conditions and exposures. And so how does sex and reproductive aging fit into these more complex models of aging? So I'll just describe briefly one example. So this was a deeply phenotyped cohort of over 10,000 individuals in the general population between ages of 40 and 70. And there were a few findings that were really relevant to our discussion. So one of the things that the investigators did was they grouped these multi-omics features into 14 distinct feature groups that were representing major physiological systems and environmental exposures. And then they modeled age from each of those 14. And what they found was that of these 14 models, there were several of them that showed a really profound difference in performance by sex. For example, I've highlighted here in the red box over on the left that if you build a model predicting age with blood lipids only, their metric that included all their multi-omic lipid features, that had 51% predictive power for chronological age in females, but only 31% accuracy in males. So a major difference there in how that one system predicts age. And we know that these models then differ by sex, at least in 4 of the different parameters, but what about the impact of menopausal status? And so for that, they took a subsample of women for which they had information at the menopausal transition, and they matched them 1-to-1 across chronological age. And in 4 of the 14 models, they saw that the menopausal status was significantly associated with the performance of the model. And these 4 were the immune system, blood lipids, the hematopoietic system, and renal function. And what I've highlighted over here is showing how the model changes over time. So in the top part here is the blood lipids model in males over the age range between 40 and 70. And you can see it's a nice sort of flattish line going up. And in the female cohort, there's sort of a sigmoidal inflection. And that inflection is occurring right after 50 years at around the predicted time of menopause, showing that this is not the same type of curve and that for women, there's a sort of inflection point in the model performance over age that is correlating with reproductive aging. And on the bottom part here, I'm showing lifestyle, which is a variable that apparently doesn't change as much or doesn't change in the same ways through the menopausal transition, but we'll have to refer back to Bridget about that. But what we see here is that the curves are essentially the same for males and females with this sort of uptrend in both of them, not showing this sort of sigmoidal inflection that we see for the lipids model. So to summarize this part, this initial data from both clinical studies of, for example, cardiovascular disease and multi-omic phenotyping highlight the need to consider aging and reproductive aging specifically in women. And I emphasize this just because so many of us are doing research in this area. It's really important to really kind of parse the questions. And I'll just note here that none of this data that I've shown really speaks to the potential significant intersections between HIV, antiretroviral therapies, and menopause. They're not captured in these larger population-based cohorts. And I would point to as an example of some work that's really highly relevant in those areas, work by Rebecca Abelman and Phyllis Tien from the MaxWise combined cohort looking at body composition, and also Markel Azani and Sarah Luby and colleagues on cardiovascular disease, just to call out a few of the other specific areas where we have more information about menopause and HIV. But now for this talk, I'm going to focus back onto viral and immune features. And notably, the immune system parameter in that large population database was one of the things that came up. And so this leads us to our sort of primary question. What are the implications of menopause for the immune system and the HIV reservoir? So to sort of focus on that, I'll first start with talking a little bit more about estradiol. So waning of estradiol is one of the cardinal features of the menopausal transition. So how does estrogen cause all these effects on all sorts of body systems? So this is through both direct and indirect effects. And it's partially mediated through multiple receptor types. And one thing to highlight here is that there's cell type specific receptor expression. So what I've shown here is ESR1 or ER alpha, ESR2, the gene that encodes for ER beta, and then the G protein coupled estrogen receptor all the way over on the right. And I've shown 3 different immune cells here, naive B cells in blue, T cells in red, and monocytes in yellow. And what you can see is that the receptor expression within these immune cells is not the same. So as we talk about how estrogen, quote unquote, mediates effects, we also have to think about what receptors are available for the immune system to integrate those signals. And I'll just also mention briefly that most of what we know about estrogen signaling comes from breast cancer cell lines, so we really only have a nascent understanding in the immune system. So once it gets to the cell and encounters its receptor, there's a number of different ways that it can mediate effects, but don't worry, we're not going to focus on all of them. For this initial discussion, I'm just going to focus on the classical genomic pathway. So this one, estrogen comes in, it ligates ER alpha, encoded by ESR1. That combination of the ligand and the receptor goes into the nucleus and it drives transcription of genes. So let's just keep that in the back of our heads as we now move on to talk about how menopause impacts immunologic and virologic outcomes of HIV. So this here is one example of some of the work that's been done. This was led by Brandi Lynn Peters from the MaxWise combined cohort study. And the Ys at the time, the plasma inflammatory profiles over time among women as they go through the reproductive transition. And so in this study of 350 women with inflammatory markers and markers of gut barrier function measured at over 600 visits over a period of around 2 years, they saw that being postmenopausal was associated with higher innate immune activation as measured by soluble CD14 and soluble CD163. And they also saw that in a piecewise linear mixed effects model, that the biggest sort of disruption was right around the perimenopausal transition, in particular for soluble CD14. So these data suggest that the perimenopausal transition in particular may be linked to increased innate immune activation. And to keep in mind that there's not like a nice smooth linear decline of estrogen during the perimenopausal period, but lots of peaks and valleys, and this may in fact have an inflammatory effect. Now, the immune cellular impact of menopause has been a focus of work led by Sarah Janella and John Karn, along with Kathleen Weber, Alan Lande, Todd Brown, and others who are all fascinated by hormones. And in this study, we've used the rich data of the MaxWise to identify individuals across reproductive stages using both hormone measurements and self-reported STRAW criteria. So this is some data from an initial investigation of 20 women sampled across 10 years through reproductive aging. And these participants had a median age of 45 at first sampling, 67% were African-American, and had sustained viral suppression and a CD4 count over 500. There's more information on this in a poster that was presented at CROI this past year by Dr. Konstantin Leskov, so please refer to that for additional details. But what I'm showing here is single cell RNA-seq from one participant. And on the left is when you use those genes to cluster those individuals into cell types. And on the right is when you overlay the menopausal status of the woman at the time of the sampling. So now let's focus in specifically on CD4 T cells and look at what happens to them. If we allow the CD4 T cells transcriptional profiles to cluster, they form 9 different clusters. And then what we did was order those clusters based on the representation of samples that came from either pre, peri, or postmenopausal time periods, and created this sort of 0 to 9 transition to being mostly postmenopausal at the top and mostly premenopausal at the bottom. And then what you can do is overlay genes that show significant differences during this transition. And as you can see here, for some of them, including the IL-7 receptor here and JUNB, an important transcription factor, that there is what appears to be a transition as you go through this reproductive aging in the amount of gene expression. Now, stepping back from those one single individual example to a more broad look at the cohort from the single cell, what I'm showing here is the top differentially expressed genes across reproductive stages. The size of the circle indicates the percentage of cells that were expressing the gene, and the color indicates the level of expression at a particular stage. So among these top differentially regulated genes, there are multiple ones related to inflammatory pathways, particularly through the tumor necrosis factor and NF-kappa B pathways. But again, similar to the work from Brandy Lynn Peters and colleagues, if you look, there's a lot of red hot expression here of some of these inflammatory mediators in the late perimenopausal. And that is much quieter postmenopausal and even a little bit quiet in the premenopausal. So again, suggesting that this period of transition, which can last as long as 10 years in some women, may represent a period of higher levels of inflammation where we need to focus efforts on managing potential comorbid complications or what may be happening to the HIV reservoir. So now I'll shift to talk a little bit about the reservoir itself. So here I'm showing some data that was also published by the team led by Sarah and John Karn. And here showing what happens to the inducible HIV reservoir as women are transitioning through reproductive stages. Previously, work done by my group and others have shown that in premenopausal women not on hormonal contraception, there are lower levels of residual virus activity in the reservoir. And what we observed during this menopausal transition study was that there's an increase in this activity as you go through the transition. This is also recapitulated in a very small look from an ACTG study. What they've shown here is 3 different patterns of what happens to the reservoir over time. And one of the patterns that can happen to the reservoir is this sort of hockey stick appearance where the reservoir comes down, comes down, comes down, and then inflects back up. And what was interesting to us is that this pattern was observed in only 2 participants, and both of them were women who would have gone through menopause during the time of the study. So potentially consistent with what we'd observed in our cohort-based study. There's also a suggestion of sex differential accumulation of proviruses in women versus men on long-term ART. That was work presented by Matthias Lichterfeld and Zhu Yu at CROI last year. And this suggests that there may be differences in the overall character of the reservoir between males and females. So now, is waning estradiol really driving the immunologic and virologic changes? Like, is this what's happening? And would that be reversed by hormone therapy? That's one of the questions we're going to try to answer with the HOT study, looking at what happens when you replace some of that estrogen. But it is true that we have work, this is work done a while ago with John Karn's group, where the estrogen receptor was shown to be active in HIV latency reversal models in vitro models. And then when we took cells from individuals, we showed that by trying to stimulate them in the presence of added estradiol in culture, you could really efficiently block HIV transcription. So in my lab, we decided to look specifically at whether or not how estrogen was blocking HIV transcription. And we're a bit short on time, and I want to make sure we have time for questions, but I'll just take you briefly through what our reasoning was for these experiments. So what we thought was, well, HIV transcription, the production of HIV RNA, is entirely controlled by the same things that control host gene transcription. So if adding estradiol into the system affects HIV, it should also affect other genes in the same pattern. So we took CD4 T cells from healthy donors and we stimulated them with and without estrogen and looked at the patterns of what happened to genes. We were looking for genes that might be regulated in the same way as HIV and also genes that might themselves regulate HIV. So we looked at 2 different time points, an early one at 6 hours and a later one at about 1 day. And what we saw was differential regulation of genes specifically related to metabolism, cell cycle, which is cell division, and immune function. And we saw a kinetic delay between males and females. So cells from females showed a more rapid response to the estradiol stimulation, with cells from males catching up, although not fully getting to the same level at about 24 hours later. But one of the other things that we observed was that we saw no enrichment whatsoever in genes that are supposed to be directly regulated by the estrogen receptor. So we looked at all of these genes that have an estrogen regulatory element in their promoter, and we didn't see any changes in their expression. We then looked for the protein, and we couldn't find the estrogen receptor in the nucleus in T cells, although we could easily see it in our control MCF7 breast cancer cell lines. And we also saw that the estrogen receptor was slightly different in size when you looked in T cells as compared to the breast cancer cell line. So then, to summarize several years of work, we ultimately found that this version of the estrogen receptor that's expressed in T cells is actually what we call a splice variant. So it's lacking one portion of the regular estrogen receptor that's been described many times. And it likely does not go into the nucleus very frequently and does not cause direct transcriptional changes. And so that's not how it's impacting HIV latency. So the answer to our question is the first hypothesis is not correct. So this regular pathway is not the one. This left us with many other possibilities, which we're actively investigating, whether they're signaling through other receptors or whether it's the regulation of cellular metabolism, which we saw a lot of changes in that, in how cells use energy. That is actually what's causing the differences in HIV transcriptional expression. So to summarize this, going back to the beginning, aging and menopause are both distinct and overlapping, and this is just a plea to consider that in any research on aging, and in particular for certain of these features that show a much more profound impact in women as compared to men. And second, that there are immunologic and HIV reservoir impacts of reproductive aging, with that transition period of perimenopause as a specific time when there might be significant changes in immune activation and reservoir stability. And then finally, I would suggest that really separating the mechanisms of these impacts is going to be hard to do, but we need to understand what estradiol is doing in the immune system, and as we're trying to do currently in T cells, in order to have a better understanding of how we might intervene to either promote things that are good or to block detrimental inflammatory side effects. So some suggestions about future directions, I think in longitudinal studies, integrating multi-omics from both plasma and cellular analyses, and also analyzing those while considering HIV reservoir size, HIV integration site, and how readily HIV is expressed. And then also looking at changes in T cell clonal dynamics over time will all be really critical to defining what the impact of menopause is on all these features. And then as far as isolating the effects of estradiol exposure itself, we have lots of work to do with in vitro experiments. And then the idea of analyzing with ADVAC, as is possible with the design of the ACTG 5424 hot study, will really help us to better understand exactly what we can intervene on. So I'd like to thank Erin Michielsic from my lab, who did a bunch of these studies, and then the many, many people who have thought about hormones at length with me, and happy to take any questions.
Thank you so much, Eileen. It has been great to move from that lived experience that Bridget gave to the more clinically oriented, how do we deal with this? What is menopause? How does it interface with HIV? What are the side by sides, and how does it affect HIV and vice versa? And then to hear this mechanistic pathway. So we open this up to folks who have questions, and we already do have a few questions in the chat. One question is technical, is that Delta 7 splice variant in all subsets of CD4 plus T cells, and in tissues as well as blood? And what about in other cells harboring reservoirs? And then we can go back to some of the prior questions, specifically other cells such as microglia.
So Nadia, thanks so much for the question. So we don't know for sure. We used resting CD4 cells, but we did not specify cell identity subtype beyond that level. And also, we have looked in some other immune cells from only periphery, though. We haven't done any tissue work at all. And I think there are already some data about interactions between estrogen receptor and other factors in the CNS, but we don't have any information about which splice form is present. And I'll also just mention really quickly, you can't actually use the large sequencing databases because the frequency of expression is so low that it misses the splice variants.
Thank you. Great. Serena had wondered about the impact of tenofovir or TDF specifically on bone loss for women living with HIV during menopause. Do we have any understanding of that? I know some work has been done, but I'm not sure how it fits with menopause.
Yeah, it's a great question, Serena. So what we know about for antiretrovirals in bone is that a lot of the negative impact of it happens with initiation of the antiretroviral regimen. So within the first 2 years and largely within the first year. And then there's some improvement of bone density thereafter, but doesn't recover back to what it was at baseline. And it's worse with regimens that include tenofovir disulproxyl fumarate as compared to TAF or other regimens. But what this specifically does in the menopausal transition, you can think of it in two ways. One is if you're already on a stable regimen with a TDF regimen, it doesn't seem to impact very much. It's largely just what happens with the estrogen loss. And that, we sort of looked in our menopausal studies, and we can show clearly that there's a difference between people with HIV undergoing the menopausal transition and the amount of bone loss that they have. But within the group that are HIV positive, there was no signal for those who were already on tenofovir. But certainly, I think if you're initiating that regimen around the same time, you're going to have an additional impact of that.
And there's a question about current messaging. What would you recommend in terms of hormone replacement therapy? And someone asked specifically about testosterone.
Oh, you mean testosterone for bone? Let me see. So hormone replacement therapy, I think what we do need to talk more about is who we really should consider, right? And I think for people who are experiencing moderate to severe vasomotor symptoms, especially people who are younger than 60, we really should have the conversation about whether or not some short-term treatment with hormone replacement therapy, that is with estradiol based, would be helpful for relieving the vasomotor symptoms. The testosterone would not be helpful in this situation. It's really the estrogen that's going to be helpful in relieving the vasomotor symptoms. There was another question earlier on also about why is exercise not recommended or yoga? And that's a great question too. The data that I summarized there are from the recommendations from the North American Menopause Society. And so they're basically looking at all the data that's out there, and they put primacy on randomized clinical trials and well done ones. And so basically from those trials, there isn't enough evidence that exercise and yoga really improve vasomotor symptoms. But there's a lot of subtlety to that because it depends, for whom the study was done on. And I think for people, most of the studies are done on people with moderate to severe vasomotor symptoms. So exercise and yoga may not be helpful for those people, but maybe for mild symptoms, it could be. And so I think that that's the caveat for all those recommendations. What they're really trying to get you to focus on is good therapy for people who have moderate to severe symptoms. And those, the first choice is hormone therapy with estradiol.
Great, thanks.
Great. And I think you actually answer all the questions in the chat. There's one I missed.
Can we just give Bridget folks were interested to know from the Well Project what's out there about menopause?
Absolutely. And thank you for asking that question. We are, and it's really exciting. I'm super excited about it. We are actually planning a roundtable in October that's going to be focused on women and HIV and menopause. We have a program called Women Like Us, which is focused on women that are aging with HIV. I will drop the link in the chat. There are resources included there. We also have fact sheets on menopause that are available on the website. So there's a plethora of information basically at the end of the day. And just real quick, I want to pop in. Eileen said something that triggered me, which she always does, because I always learn something from her. She said that menopause is not equal to aging. And I also want to just kind of add in there that menopause and aging are not equivalent to loss of sexual health, wealth, and desire for women. And so even as women are reaching the end of their reproductive life, so to speak, doesn't mean that we should stop having conversations with them about sexual pleasure, sexual health, and sexual wellness.
So wonderful. And thank you so much, Bridget, for those comments. I want to acknowledge a couple of other comments in the chat from Lauren Suchman, who is offering some results that she's going to present in the Menopause Society meeting on provider experiences in managing menopausal symptoms. And she's offering to share the findings. And we also have some comments that I think after today we all agree on, which is, we know for many, 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 many years that hormonal replacement is indicated to treat menopause, and providers should really feel comfortable, more comfortable about treating menopause, both for women with and without HIV. But especially, I think I'm really, really excited about how the HOT study, what the HOT study is gonna show us. I think it's very reassuring to know that there are not really negative findings to date in other studies, and really looking forward to hear what the HOT study is gonna show us, because we really need to learn more and also be more comfortable. I think patients asking for it, providers being able to give the right information to our patients, and also treat them and really address menopause as a condition that affects all women, and in particular women with HIV. So thank you very much, everyone. Thank you, our wonderful speakers. Thank you, our participants who came from all over the world. And that was great to see so many people from so many places. A few announcements before we close. Our next webinar will be on September 10th at noon Eastern time. And the topic will be disseminated soon, as well as a safety date. I also want to share information about the upcoming HIV and Women Symposium that will be held on November 13th. It will be a full day symposium, and it will be virtual. And there will be also a save the date and a registration link coming up soon from the CFAR. So please keep an eye on those announcements. There will be an abstract submission website. So if you have things that you haven't sent or submitted or think would be of interest for this symposium, please keep an eye. We will be opening the abstract submission sometime over the summer, and look forward to seeing you in future events as well as in our symposium. Thank you, everyone.